Good evening everyone, can you hear me clearly? Okay. كل عام وانتم بخير. أتمنى ان انتم تكونوا قضيتوا أجازة سعيدة. Regarding the last week, this is going to cause a problem for us, especially that again other vacation are going to coincide with can you hear my voice now, Aisha? Okay. I think that other vacations are going to be also on Thursday. That's why today I'll try to continue the part regarding the concepts of healthcare. Plus, I'm going to give you another part related to the foundation of quality improvement. You are going to go through the methodologies now. I'm trying to give you this lecture so that you can start your first assignment immediately. Okay? Because the first assignment you are going to compare between two methodologies. This is one part of the assignment. Then there is you are going to compare between the outcome and the approaches or in general of healthcare. You have taken it in the first assignment. You are going to take it also today. And then you are going to compare between two tools. This is the first assignment. Okay. The second assignment, as I told you before, it's going to be a group assignment. And you are going to prepare a poster presentation about a health problem or a program or a disease, the quality of the programs right now, or the situation of this disease, and so on. The final project, each one of you is going to select a health problem or a disease or a service, and you are going to develop a quality improvement program regarding this issue. Okay? So as you can see, the three assignments are linked together. The first assignment, in the first assignment you are learning the basics and the difference between the different methodologies. The second, you are going to analyze a situation about a certain disease, issue, service. And the third, you are going to develop a plan to improve this or a program to improve a disease or a service, and so on. Okay, clear everyone? Okay. As I told you, the assignments, the first assignment, the due date, it's going to be in the 5th week. The second assignment, it is going to be in the 8th week. I prefer that the presentation would be in the physical class, okay, in the 8th week. And the third assignment, the final project, you are going to submit your assignment in the 14th week, but the presentation is going to be in the 15th week, okay? Yes, I'll set the exact date. I think that it's going to be the Thursday of that week, okay? Okay. So let us start regarding we are going to continue the basic concepts. We had already talked about the attributes of quality of healthcare. We had already talked about the accessibility, continuity of care, and I'm going to just refresh your memory, and then we are going to continue, okay? Okay. As I told you, the attributes of quality, these attributes are important to be fulfilled so that we can have a high quality service. Okay? So the first point we talked about is accessibility. And as I told you before, when we talk about accessibility, we talk about physical accessibility in terms of the distance, the travel distance, in terms of transportation, okay? And when we talk about financial accessibility, we talk about affordability. Is the service affordable or not? Can we afford to receive this service, or we cannot? As I told you, in the Western countries and here even in the UAE, if you don't have insurance, you may not be able to afford a lot of services and a lot of healthcare services here. And even in Western countries, it's the same. Okay? And we had already covered before the organizational accessibility. And in the organizational accessibility, we talked about the structure, the organizational structure, about the administrative part. Is there a lot of routines you have to go through till you receive the service or not? Is it easy for you to receive the service or not? For example, there is a lot of paperwork or approvals till you receive the service. Okay? Socio-culture, as I told you regarding the socio-culture accessibility, is the service you are providing acceptable culturally or not? And the examples that I had given you, if I had provided a female doctor to a conservative culture or not. In certain cultures, they prefer a female doctor, especially gynecologist. Okay? But if I had provided a male physician, people will not go to this healthcare facility, and they will not accept the service. Okay? Clear? And when we talked about psychological accessibility, we talked about psychologically, is this service acceptable to me or not? For example, I had given you the example of the injection. Yes, injection. If it is acceptable or not. And there also psychologically, some people may refuse invasive procedures. Some people may refuse endoscopy or colonoscopy. It is invasive. Okay. Again, this is the psychological accessibility. Okay, and already we have talked about all of this. Regarding the continuity of care, as I told you, continuity of care, it means that the care is continuous. When you refer the patient to another specialist, there is communication between the healthcare providers. There is a referral letter from the primary healthcare physician to the specialist, and there is feedback from the specialist to the primary healthcare physician. This will provide a complete picture about what's going on, what type of service had been given to this patient, what type of treatment, the diagnostic procedures, and so on. When I know about all of this, I'm going to avoid repetition of prescription. I'm going to avoid repetition and waste of the time and money in doing diagnostic tests. So continuity of care is one of the pillars of the quality. And another thing I told you about is that something like family medicine and primary health care right now, it is completely dependent on the continuity of care. Continuity of care here I'm providing health care to all members of the family, to all age groups, and from birth till death. Okay, that again is a type of continuity of care. Okay, how can examples of interaction in the continuity of care? If there is missed follow-up appointment, missed laboratory tests, the patient didn't perform, or there is no feedback from the specialist, no feedback from lab, incomplete recording of the data of the patient is a type of discontinuity of care. Okay. Also, if there is inadequate communication between the health professionals, we cannot, we don't know about the other healthcare provider. We don't know about the treatment given by the other providers. We don't know about the diagnostic tests that they are doing, especially in patients who need a lot of specialists. Okay. He has a chronic disease, several chronic disease, and there is endocrinologist treating diabetes, for example, a cardiologist treating a heart condition, and a dietitian, for example. 3 different healthcare professionals are providing care, and they don't know what the other is doing. This is going to cause waste in the time of the patient, waste in the resources of the health services, if they are repeating the tests and the lab tests, and if they are repeating treatments and so on. Clear, everyone? Am I going too quickly for you? Should I slow down a little bit? Okay. If anything, if you need more clarification, please just write or use your mic and ask. Okay. So this is the continuity of care. Regarding the appropriateness of care, as I told you, appropriateness of care. Am I providing service which is relevant to the patient or not? It is relevant to the patient's needs, okay, and according to the current state of knowledge, okay. I can measure it by the extent to which the intervention, the benefit exceeds the risk. For example, if I had prescribed an invasive procedure to the patient, okay, I'm going to weight here the risk. If this invasive procedure is going to cure a disease, or it's going to diagnose performing this invasive procedure, it's going to save the patient, or I'm going to do a risk for the patient. I'm going to, for example, the anesthesia, the infection, and the invasive procedure itself, the complication of the invasive procedure may exceed its benefit. That's why if I'm choosing a certain service, the benefit should outweigh the risk. Okay? Again, these are examples of inappropriate care, which is done correctively. For example, the physician had done a surgery in a correct way, but it is unnecessary surgery, okay? Or he had given unnecessary blood transfusion, unnecessary administration of drug. We had talked about this before. If you remember, some physician would prescribe the drugs just to, if you know that some patients may press exert pressure on the physician, so that the physician should write, yes, like antibiotic, like the supplements and the vitamins. Okay, some patients may push the physician to write unnecessary medication. Okay, if the patient is having a viral infection and you are prescribing antibiotic, here the antibiotic is unnecessary for this condition. Okay, except if you are doing a prophylactic against secondary infection, secondary bacterial infection or something like that. Okay. I had subjected the patient to unnecessary laboratory or radiological investigation. Okay, they are done correctly, but it was unnecessary for the patient. All of these are waste. This is waste of resources. Regarding the technical competence, we are talking here about the competence of the healthcare providers. Are they qualified to do the right thing right? This means that if he is a surgeon, he's going to do the surgery right. The physician is going to prescribe the medication in the right way, okay, in the right dose, providing the necessary information about how to use the drug, the frequency, and for the duration, for how long the patient should use this medication. Okay, and he can also provide the patient with information about the side effects, about any signs and symptoms for discontinuity of the medication and so on. Example of doing the right thing wrong. If I had given a certain medication for a wrong time, and the best example is antibiotics. We may find that it is common that some physician would prescribe antibiotic in a wrong way. They prescribe the antibiotic, the frequency is wrong. For example, if the antibiotic should be given every 8 hours and he had prescribed it every 12 hours, this is wrong. If the antibiotic duration should be 5 or 7 days and he had prescribed it for 3 days, or he didn't tell the patient for how long he should take the antibiotic. Yes, especially for kids. You know that certain antibiotics, the bottle itself, especially for children, the bottle itself may not be, one bottle may not be sufficient for the whole course of treatment. That's why you should tell the parent that the amount, the dose, for the frequency per day and for how long. And if you know exactly that one bottle is not sufficient, please tell the patient, take care that you may need more than one bottle, okay? And it's the same for the adults. Sometimes some antibiotic, a single package may not be enough for the whole course, especially if it is going to be for 7 days or 14 days. Okay? Clear, everyone? Another example of doing the right thing wrong. Okay, you had prescribed injection, okay, but the route that you had administered this injection, it is wrong. For example, certain injection should be subcutaneous, and you had administered it intramuscular, or it should have been intramuscular and it was given intravenous. It should have been intravenous and you had given it intramuscular. All of this is wrong. Okay? Or taking the blood sample in a wrong way, especially if we don't follow the infection control measures. Again, this is a fatal mistake. You may cause blood-borne infection to this patient. Also, there is a preventive intraoperative complication if for example, if a surgeon had done an error during the surgery. He had injured a vital organ, or he had cut an artery and caused a lot of bleeding, or he didn't administer antibiotic before the surgery, starting the antibiotic and prescribing antibiotic after the surgery. This may cause infection for the patient later on. Exactly. Exactly, Aliyah. This is the rules of quality and the rules of prescribing medication in general. Okay, up to this point, do you have any question? Okay. In the first lecture, I had talked about the difference between efficiency and effectiveness. If you remember, efficiency means no waste. Effectiveness means I'm going to achieve the goal. So, if we are talking about effectiveness, this means that the degree to which I had reached the desired outcome. For example, I had prevented the mortality, I had decreased the morbidity, I had prevented complication, the quality of life of the patient had improved, the disease is cured, the signs and symptoms decreased, the disease severity decreased, and so on. All of these, also by health education, you had increased the knowledge of the patient about his condition, about the complication of this condition, and about how he can take care of himself. For example, the diabetic patient, the rule is that you should teach the diabetic patient about how to monitor his blood sugar, the flag signs related to hypoglycemia and hyperglycemia, how to differentiate between lowered blood sugar and increased blood sugar, when to seek medical advice, how to administer injection if he is using insulin, about how to I told you monitor the blood glucose level, and how to take care of his foot to prevent diabetic foot, and so on. Okay, clear everyone? So these are effectiveness. And if I want to measure this effectiveness, I'm going to measure the mortality rate, the morbidity rate, the cure rate, the knowledge, the patient satisfaction, improvement in the quality of life, the functional mobility of the patient or restoration of function, and so on. Okay? These are examples of the indicator used to measure the effectiveness. Regarding efficiency, as I told you, there is no waste. No waste of time of the patient, no waste of time of the healthcare provider, no waste in the resources of the healthcare service, no wasted resources, and no wasted money in general. Okay? And no wasted effort and time. Cost, effort, and time. Examples of wasted in waste in the healthcare. As I told you, if there is no communication between the healthcare providers, there is going to be a repetition of the diagnostic test. This means that you are wasting the resources of the health services. Okay, there is repetition of tests. You are not only wasting here money, you are wasting the time of the healthcare providers and the technicians, in the lab technician, and so on. You are wasting also the effort of the patient and the physician. So also regarding the feedbacks and so on. Again, this may cause waste of resources. And also another example of efficiency. If you remember, I told one of the things that previously was there in the health, in hospitals in general, there was a centralized nursing station, okay, nurse stations, okay, in the hospital. So the nurses are, for example, in the first floor, and they, if they want medication and if they want to go to the department, they were traveling between the different floors. Right now, they had diminished this waste of the time and the efforts of the nurses by providing stations, nurse station in each floor and in each department and so on. This had decreased the efforts of the nurses, and they had provided them with cabinets of the medication in each floor and so on. Okay, these are examples. Another example is the ergonomics. You know what is meant by ergonomics? Did you hear the word? Yeah, the body mechanics. Ergonomics here, you know that right now the equipments, all the equipments, even in the offices and desks and so on, they are designed so that to decrease the pain and stress and strains in our bodies. So right now the healthcare equipments in general, or medical equipments, they are respecting these ergonomics. For example, you are going to see adjustable operating theater tables, adjustable according to the height of the surgeon. Okay, if he is tall, they are going to adjust the table so that it is going to be easy for the surgeon to do the surgery. The same for endoscopy and the ultrasounds and all of these. They are respecting ergonomics to decrease, yes, not only safety, to decrease the strain and stress in the body of the one using it. Also during transportation, Farida, yes, right. The patient right now, they can provide portable X-ray, portable ultrasounds, so that we will not transport the patient from one department or the other, and then this may cause injury to the patient. Okay. Also, you can see the ergonomics even in the desk and the mouse used, in the keyboard used, in the right now even the chairs of the adjustable according to the height and according to the person using it. These are examples of the ergonomics. Okay, clear? Okay. Patient-centeredness. Patient-centered, as I told you, did we go through patient-centered the first week, or we didn't reach it? Okay. What is meant by patient-centered? Patient-oriented. But again, elaborate more, Iman. Focus on the patient. Focus on the patient what? Yes, the main thing is the patient. Patient what? Exactly, Aliyah. What they need. What they need. Yes, what they need. Once you have provided the patient with what they need, you are going to achieve the satisfaction and care. Okay? So, in patient-centeredness, we are going to provide health care we are going to involve the patient in decision making about their treatment plan, and we are going to provide them with care according to their needs, expectation, and differences. This will be reflected on the patient satisfaction and adherence to the treatment. Okay? Yes, it's patient adherence. Okay? And as I can't remember if I told you this or not. Adherence is is a stronger word than compliance. If I'm talking about compliance, as if someone negatively taking instruction and he's complying, he's just obeying the rules. Okay, but in adherence, he's exerting efforts, he's doing efforts so that to follow the treatment plan. Since he's doing effort, this means that he was involved in the decision making about the treatment option. I'm going to tell the patient about all the options, the treatment options available for his condition, and together we are going to choose the best treatment for the patient. This way, you are going to ensure that the patient is adherent to the treatment and his satisfaction is going to increase. Clear, everyone? Okay. Regarding the dimensions of patient-centeredness, we are going to respect the patient's value, preference, and needs. For example, if he is afraid of injection, okay, I'll try my best to provide him with other alternatives. But if there is no other alternative, I'm going to try to help the patient to overcome his fears. Okay? Also, there should be coordination and integration of care. Integration of care, this means that I'm going to combine several treatment plans and I'm going to provide it in one session. For example, as I told you, if the patient is a diabetic, hypertensive, and he is suffering from ischemic heart disease, so he has a lot of conditions. When the patient comes, I'm going to provide him with treatment for all his conditions. I'll not provide the treatment for diabetes this session, and then next session I'm going to give treatment for hypertension, and this is a waste of the time of the patient, and this may cause the patient, how can I say it, that he will not be adherent to the treatment, okay, because there is no integration in the care given. Also regarding the information, communication, and education, again, this you are going to provide information, health education, brochures, support material to the patient according to his condition and his needs. Okay? Clear? Another thing, we should respect the physical comfort of the patient, okay? This means that physical comfort here, if you are providing the examination and the interaction, it should be in a private place. There is no interruption so that the patient would not feel uncomfortable, okay? Privacy, respecting the privacy, the physical comfort. I'm providing a comfortable place for him to sit, a comfortable place for examination, comfortable. There is no noise. Also, the temperature. One thing that we should take care of is the temperature. If, for example, the AC is too cold and we are doing examination to the patient, he may not feel comfortable during the examination session. Also, emotional support. We should provide support to the patient if he is afraid about something, if he's stressed or distressed. I should provide emotional support. And also, we should provide enough information to the caregivers or the family and friends. They should be involved in the decision making and the treatment plan. And also, we should provide support for the caregivers. Clear? Okay. Regarding the safety. What are the rules of safety in healthcare in general? Not only in quality, but the rules of safety. Risk management, what else? You know that the oath all the physicians do no harm. Training, exactly, no harm, do no harm. Okay? So there should be, yes, all what you had said. The patient ID, make sure that checking the patient ID, especially if you are going to do invasive procedures or you are going to do laboratory tests. The first thing that you should do is checking the patient ID. Also training of the staff in general, infection control, and the fire drills, the emergency exits drills, and so on. Documentation, yes. Complete documentation about the history of the patient, drug history, allergy, and so on. Okay? So also there should be a system to investigate any risk. There should be infection control committee in the facility. Also, there should be a risk management and root cause analysis. If there is any near miss, or if there is any error, there should be a reporting system about this error, and not only reporting, also investigation of this error. If you remember the first case study that we have discussed, there should be a system to investigate the underlying cause of the error, and also there should be a system to predict any future problems. Okay, this is regarding the safety. And if I want to measure the patient safety, one of the indicators is going to be the hospital-acquired infection. If this facility or this hospital, there is a lot of hospital-acquired infection, this means there is a breach in the infection control measure. There is inadequate infection control in this hospital, and it needs to be investigated, and the quality of the infection control should be improved. Also, there should be safety inspection, maintenance of the equipment, calibration of the equipment, training of the healthcare professionals, fire evacuation drills, systems designed to decrease the risk. If I examples, the drug profiles, the allergy documentation, incident reporting, all of this we have talked about. Clear, everyone? Okay. Timeliness. If I want to talk about timeliness, what is meant by this? It should be timely. And give me examples. On time. Yes, exactly. Not only in medicine. The care itself, it should be the question regarding the question, what is meant by timely, Iman? or timelines, not delayed, exactly. If the patient needs a certain service or a certain treatment, it should be given in time, immediately. Okay? Any delay may cause complication to the patient. Okay? Any delay. For example, if there is not a delay in the medication, starting antibiotic, for example, this may cause complication to the patient. Delay, the example that I had given you before is that if there is an accident and there is delay in transportation of the patient, this may cause even death of yes, it depends on the case. Exactly, it depends on the case. Delay in blood transfer, again, yes, this could be fatal. Okay? One example of the delays, as I told you, delays in transportation, delays in starting the treatment, delays in receiving the feedback from the laboratory, delay in referring the patient, exactly, this is a good example, delay in checking vitals and all of these, and blood, yes, all of these are delays. It may cause the life of the patient. Okay? Delays in radiology reports, in laboratory results. All of this would, yes, delays in starting or performing the CPR. There is going to be brain death, and the patient may suffer a lifelong disability, or even may die. Okay? Prevention. Right now, prevention is one of the dimensions. You know, what are the levels of prevention? Who's going to tell me the levels of prevention? 3 levels? Huh? State them. What are the levels? Primary, what else? Secondary and tertiary. Yes, primary prevention, secondary and tertiary. And if we included promotion, health promotion, you are making the healthy more healthy. Okay, so this is health promotion. Then there is primary prevention, means that before the occurrence of the disease. Here we are acting on the risk factors. Okay, primary prevention before the occurrence of disease. So here we are screening for the risk factors. Okay. Then there is secondary prevention. The disease occurred, but I want to detect the disease early before complication. Okay. Yes. I'm checking for symptoms, laboratory tests for detection, and so on, or doing certain examination for detection, like hypertension, diabetes, screening for breast cancer, early diagnosis before the complication. Okay. If the complication occurs, this means that we are doing tertiary prevention. We are rehabilitating the patient. We are providing psychological support, decreasing the disability, and improving the quality of life. Okay, clear? These are the levels of prevention. There is the primary prevention before the disease occurs. I'm here dealing with risk factors. Risk factor like obesity. Obesity is a risk factor for cardiovascular disease here, for example, or smoking for cancer. This is again a risk factor. Okay, so we are screening for risk factor, or dealing with the risk factors. Then there is the secondary, early diagnosis and treatment before complication. Tertiary, the complication occurs, so I'm doing rehabilitation and support. Okay. Regarding equity, as we talked about it already, we should provide equal care to all individuals in the society, male and female, all socio demographic classes or socio-economic classes, regarding of the income, gender, and so on. Iman, what's your question regarding primary? I didn't get the example. Family history? If you are checking for the family history, it's a risk factor. This is a risk factor. So it's going to be primary. You are going to screen, and family history, it could be in health promotion and in primary, by the way. It's a risk factor. Okay? So if the patient is right now healthy and there is nothing affected, okay, but he has a family history, you are promoting his life, changing his lifestyle, and so on. So right now it could be either primary or in promotion phase, in health promotion phase. Okay? This is, you are dealing with the risk factor, so it's primary. It's not sick yet, exactly. Regarding equity, we had talked about it. Amenities. What is meant by amenities? And give me examples. Amenities. Okay. These are like other support facilities for for providing the health service. For example, the parking space, availability of parking space. Okay, this is not healthcare service, but it's going to support or facilitate providing the service. There is available parking space so that the patient can come and have the service. Okay. Also the waiting room. The waiting room, availability of light, the comfortable waiting room, available chair, clean, proper lighting, the atmosphere is comfortable for the patient. All of these are support for the health services. Okay? Exactly. The waiting room, if the culture culturally they need to separate between the females and males in the waiting rooms and so on. Also the privacy is okay, you are providing private places so that there is interaction between the healthcare providers. Can you imagine that a physician is taking the history in front all of the waiting people in the waiting area? The patient, we are talking about sensitive information. This cannot be done. So there should be privacy. Okay? And another thing, not only privacy, there shouldn't be any interruption. While the patient is sitting with the physician, there shouldn't be each time someone knocks on the door and someone enter, and the patient may feel embarrassed and cannot provide proper history. Okay? All of this may affect the quality of the service. If you go to a health facility and you couldn't find a parking space, so you will not go to the physician, and there is a delay in the treatment, and so on. Clear? Another thing, the availability of cafeteria and food in the hospitals. Okay, you may provide a very, very good service, but the food is horrible, and the patient, yes, the quality of food is horrible. The patient will not be satisfied with his stay in the hospital because of the food. Okay? Regarding the cost effectiveness, effectiveness, is it cost effective? I mean that right now the government is paying or financing the healthcare. The benefits from this expenditure, is it feasible or not? Okay. As I told you, I can't remember if I told you this or not, regarding the Western countries, they had compared the cost effectiveness of healthcare between the different countries, okay? They found that the best were in Canada and the European countries. The United States, I think it was in the third or the fourth in the cost effectiveness. Or even the seventh place. They found that they are spending a lot of money on healthcare, but it wasn't that beneficial to the population. Okay. So the cost effectiveness, again, it reflects the quality of service given. There are two terms, risk maximization. I'm going to spend more and more money, more and more till there is no more benefit, till I reach the maximum benefit from this expenditure. Optimization, I'm going to spend the optimal amount that is going to provide me with optimal benefits. Okay? You cannot hear me, Rasha? Can you hear me, everyone? Okay, maybe the problem is at your end, Rasha. Okay, okay. Regarding optimization, as I told you, the difference between maximization and optimization. Maximization, I'm going to spend more and more money till I reach the maximum benefit. Okay? Optimization, I'm going to spend the optimal amount, just enough money to provide benefit. Okay, clear the difference between them? Okay. You have two options right now. Okay, we can take 10-minute break and return back. Okay, I mean I can repeat it and then we can bargain this. Okay. The last point, regarding the last point, there is maximization and optimization. Maximization, you are going to spend more and more money, maximum amount of money till you reach the maximum benefit. Okay? Then there is optimization, you are just going to spend enough money to get the acceptable benefit. Okay, clear? Okay, clear? So, do you want the break now, or at 8:30, or what? Tell me. Okay, 8:30. Okay. If we talked about the different perspectives of healthcare, if I'm talking about healthcare, if I'm considering the quality of healthcare from the patient point of view, from the physician point of view, and from the manager point of view, and from the one who is providing the finance or the third party payment, is it going to be the same, or there is going to be different aspects or different perspectives of quality? Different. Okay? So, if you remember the attributes that we had talked about before, right now, the attributes, okay? For the patient, if I'm talking about the patient, which attribute is more important to the patient? Let's have this. The slides related to the attributes. Okay, here. As a patient, let us think like a patient. Which of these 13 are more important for me as a patient? Accessibility, yes. What else? Safety, what else? Cost, effectiveness and efficiency, patient-centeredness and timeless. Exactly. If I am a patient, it is more important for me that it is acceptable and it is patient-centered and there is safety and timely for me. Okay? If I'm talking about the healthcare provider, if I am a healthcare provider, yes, the safety first if I'm a patient, but also accessibility and affordability. It is very important for me if I can afford this or not. Okay? Regarding the health professionals, they are going to talk about the appropriateness, technical competence, the effectiveness. Okay? And safety again. If I am a manager, I'm going to talk about the efficiency and effectiveness, about the safety, and the most important thing is cost effectiveness. Cost effectiveness. But if I'm talking about the society in general, the society or the community, you are going to see that equity is the upper. It's going to be the upper hand. I'm providing equal services to all the population, and prevention and cost effectiveness again. Okay, so let us go through these slides. Okay, here there are the patient, the policymakers, the healthcare provider, the facility managers, the society, and the third party. And the third party, as I told you, these are the payer. For example, if the payer it's health insurance or the government and so on. Okay, who is paying for the service? Here, the clinician. The clinician, the most important thing for them is the technical performance. Exactly, it's important, but different levels, Iman. Okay, the technical performance is very important for the clinician. Appropriate technical competence and effectiveness. Okay, they want to see the outcome. They want to see cure. They want to see no complication. Okay, so this is the clinician. If we talk about the patient, again the outcome, health outcome, interpersonal aspect of care, the amenities of care. As I told you, a patient may enter a facility, and the most important thing for him is the food or the interpersonal communication between the physician. The physician didn't listen to me. The physician didn't have enough time to sit with me. The physician didn't tell me about what to do. Okay, all of this is going to affect the patient satisfaction. The third party payer, okay, I'm going to pay for this service. It is important for me there is no waste, efficiency and cost effectiveness. Okay, for me it is important that there is going to be no waste and cost effectiveness, optimum care. Regarding a manager, again there is no waste, cost effectiveness, equity, and the amenities of care. Regarding the society, they are going to focus on accessibility, equity, technicality, efficiency, and cost effectiveness. All of this is important for the society. Okay, clear? So as you can see, okay, all of them are important, but at different levels or different priorities. Okay. Type. Regarding the quality assurance and the quality control, the quality assurance itself, it is the system itself. Here the system that's going to deal with the quality of service. Okay? But quality control, it is the tool, how I'm going to do this. Okay? How I'm going to assess the quality. What type of data I'm going to collect. What is the key performance indicator I'm going to measure. What type of tool I'm going to use. Am I going to use a survey? Am I going to use a checklist or in interviews or observation? Okay. So if I'm talking about quality assurance, it's the system itself. There is a plan integrated within the system to ensure the quality. But the control itself, exactly. The bigger term is the assurance, but part of it is the control, or the process itself is the control. Okay. Here we need to concentrate a little bit. Okay, for this part and the coming part. Okay. Assurance. Okay. The word assurance itself, there is a system. Okay, there is a system and a plan to ensure that the quality is followed. Okay, it's the process itself. Okay, the control, how you are going to control this quality, the tool by which you are going to measure. Okay, so quality assurance is a bigger terminology than the control. Clear? Assurance is the system. That's why it is the quality assurance unit, not the quality control unit. It's called quality assurance unit. Okay? But the control itself, yes, not only the indicator. Here the control, you are going to go through a process itself. Okay? You are going to specify the standards, you are going to collect data to compare yourself with these standards, and you are going to diagnose the differences and gap, and you are going to take measure to correct the gap. Okay? It's part of the quality assurance. Okay? So, not indicator of assurance, it's part of the assurance itself. Control is part of the quality assurance. This is how actually you are doing the quality assurance. How you are controlling it, the process by which you are controlling it. You had developed a checklist, okay, and you are going to use this checklist to collect data. And according to this data, you are going to compare it with the standards, the key performance indicators that you had placed for yourself. Okay, you found that okay, I had fulfilled this standard. So right now, I had controlled the quality of the service. Yes, Aisha, exactly. It's the tool that you are controlling the system or running the system. Okay. It's terminologist, just terminologist. Clear, everyone? Do you need more elaboration or something? Don't hesitate to tell me. Okay. Regarding the Dunabedian triad. Dunabedian triad, if we imagine that the quality is a CPU, okay, a computer, there is going to be input, okay, there is going to be process, and there is going to be output. So if we are talking about quality, there is going to be input in the form of structure. The structure here, it is the human and non-human resources, the resources, okay? These are the inputs. Then there is the process itself. Process here, example of process is the care delivery process. How interaction between the patient-physician, for example, surgery, withdrawal of blood, infection control process. All of these are process, okay? And the outcome, here the outcome is patient satisfaction, mortality rates, morbidity rates, complications, cure rate, signs and symptoms, pain control, decrease in the severity of the case, and so on. All of these are outcomes, outputs, okay? So these are the three approaches of healthcare quality. A part of your first assignment, you are going to pick up two of these three, and you are going to compare between them and provide research papers about these, okay? You are going to search for research papers that had focused, for example, on the structure, or had focused on the process, or had focused on the outcome. You are just going to provide a link or the title of this research paper, okay? So this is a part of the first assignment. And another part, you are going to compare between two methodologies, and the third part, you are going to compare between two tools, and we are going to take it later on, the tools. Not next week, the week after, okay? Clear? So today you can start your first assignment. Fresh after hearing the lecture, start your first assignment, okay? At least the first two parts, till we take the third. التاريخ, it should be submitted in the 5th week, عليا. And all the details are provided in the assessment document, okay? Officially, this should be the 3rd week, okay? But no, I'll not specify a word number, عليا. The date is going to be the Thursday of the 5th week, the timing of the lecture. Or it's better to be Wednesday. Disconnect and return back, Rasha, it's okay. What about the assignment? The assignments, as I told you, I had provided you with the assignment documents, the assessment documents. Assessment documents, you are going to see all the details of the first, the second, and the third assignment. The first assignment is individual. It is comparison between two approaches, two methodologies, and two tools. So after finishing today's lecture, it's better for you Thursday or Wednesday of the 5th week. Tell me. Thursday. I know it. Okay, Thursday of the 5th week. Yeah, okay, Thursday. Okay, so the deadline is going to be the Thursday of the 5th week. I'm going to specify the week, okay? Of the exact date. But I had told you, Thursday of the 5th week. 23, okay, it means that 11 o'clock, 55, okay? To be very meticulous, okay? At 11:55, the deadline. Okay? Regarding the structure, the process, and the outcome, let's start this part. And as I told you, this is very, very important. So concentrate. Concentrate. First of all, if we are talking about resources, there is going to be human resources and non-human resources. And when we are talking about human resources, we are talking about the number of healthcare providers, the qualification, experience, and balance. Okay. For example, regarding the numbers of physicians, are they available or not? As I told you, if there is a lot of children in a certain society or a certain community, okay, this means that I need pediatrician, available pediatrician, and I need pediatrician, a lot of pediatrician. For example, I need 10, 20, or we should specify the number, okay? So the numbers of the healthcare providers, their qualification, their experience, and also the balance. The balance, you know, do you know the standard regarding the primary healthcare clinics or family clinics? Per clinic. How many physicians should be per clinic? If you have a primary healthcare center, okay, and you have two clinics within this center, okay, how many physicians do you need for this center? The minimum physician for 2 clinics. 4, exactly. This means that you need 2 physicians per 1 clinic. Why? Because you are having 2 shifts. But if you are running 3 shifts, this means that you need how many? 6 per clinic. 6 per 2 clinics. Okay? Clear? If we are talking about the nurse-physician ratio, for each physician, how many nurses do you need? For each family physician, how many nurses do you need? Four is too much, but for each physician you need 2. This means for the 2 clinics you need how many nurses? 8. Come on, 8. Right or wrong? For the 2 clinics you need 8. Okay? So for each clinic you need 2 physicians. Okay? For each clinic you need 2 physicians, and for each physician you need 2 nurses. So this means for each clinic you are going to need 4 nurses, but here you have 2 clinics, so you need a total of 8. Clear? Clear, everyone? Okay, another rule, but this rule is according to the WHO for the middle income and low income countries. Okay, they had stated that for each family physician should serve from 600 to 1,200 families. Okay, for each family physician, he's going to serve a number around 600 families or up to 1,200 families. And here it's going to be dependent on if they are in a rural area or in an urban area. Okay? In rural area, you are going to give him more families. Okay? He's going to serve 1,200 families. But in urban areas, since we have we can provide a lot of facilities. Again, it could be 600 and even to 1,200 according to the population. Okay, But unfortunately, this standard is not being followed, because if we look at the distribution of the healthcare providers in the low and middle income countries, they are deficient. There is deficiency in the healthcare providers. Most of the healthcare providers are distributed in the main cities, while the rural and the remote areas, they are suffering from non-availability of the healthcare providers. Okay, clear? No, families, not 6,000 families, 600 families. 600 family, if we are talking about four standard family, four per family, this means 4 times 600. It's going to serve 2,400 people if they are regularly using the service. But again, unfortunately, this is not being followed. In certain areas, you are going to see that the single family physician may serve up to 1,600 families. Again, it depends on the distribution and availability of healthcare providers. Okay. I don't know about the rule here in UAE regarding physician per family. Regarding the non-human resources, we are talking about the physical facility itself. Okay, the physical facility in terms of the building, the area itself, accessibility and so on, cleanliness, maintenance of the building, safety measures, exit sign, the signs. All of this equipment, availability of the equipment and maintenance of the equipment again, and updated equipment. Okay, they are not obsolete, not old equipment. They are updated. Also regarding the supplies, regular, enough available supplies, especially the essential drugs. The administrative, the way that they are managing the system, the information system and the finance and so on. Clear, everyone, regarding the structure approach? Is it easy to assess the structure approach? Do you think if I want to assess the structure or the resources, is it easy? And how can I assess the resources? How can you assess the resources of any facility? What tool do you use? Documents. Yes. How can you collect the data, Aisha? Using what? Checklist, exactly, Fatma. We can use, no, Nora, not questionnaire. Questionnaire, if you are talking about the experiences and we're dealing with the human knowledge and practice and so on. But if you want to assess the resources, usually we use a checklist. Okay, and this checklist we are going to tick availability and the numbers and data and statistics and so on. And the assessment of the resources, it is the first step in accreditation, by the way. Okay, the first step of accreditation process is assessment of the resources. You are going to see that the accreditors, any agency, they would come with their checklist, and they are going to look at the documents and resources availability and the facility and so on. and according to fulfillment of the standards of this checklist, the first step of accreditation, it is either fulfilled or not fulfilled. If it is not fulfilled, they will not continue in the accreditation process. But if it is fulfilled, then there is the process assessment and outcome and so on. Okay? So, as I told you, the advantage of the structure approach, it's easy, inexpensive. We are using checklist and going through the or we are assessing the resources and so on. But it has got a limitation. Okay, we can have a very good facility. The facility, the building is excellent. It is built according to standards and everything, but you cannot assess the process. You cannot assess the outcome. Okay, you don't know if the mortality rate is high or not, if the patients are satisfied or not. Okay, by just going through the checklist. So another assessment methods is used for the other process and outcome. Okay. Also, if we are having a problem in the building itself, it's going to be very difficult to correct. For example, if a hospital is not built according to standard, or it is built within a very crowded area and there is no parking space. There is no area to build a parking space. There is no area to build an extension to the hospital and so on. So it is going to be difficult to correct. What do you mean that we cannot be sure that it's correct also? Regarding what? Yes, but and this means that before anyone using the checklist, he should be trained. Usually, they are a trained person to assess the structure, and it is done once. You are going to see that it is done once or every few years, because it's not feasible to each week you are going to assess the building. What will change? Okay, except in the safety measures and so on. But if we are talking about safety measure here, we are talking about process, not talking about structure. Okay? Clear, everyone? Do you have any question up to this point? Okay. I think that I'm going to stop here and give you a break. Okay? But please, it's going to be 10 minutes break. This means that we should start at 8:35. Okay? 8:35. What's going to be okay by you? Or 8:40, 40 minutes is going to be 8:35, because we still have a lot. 8:40, 40 just, okay? If it is 8:40, it's going to be just. I'm going to start. Okay. Don't be late, please. Okay? Okay, go ahead. can we start? Okay, regarding the process, so right now the structure, human and non-human resources, regarding the process itself. Regarding the process approach, as I told you, it's the technical part, the interpersonal aspects, the interaction between the physician or the healthcare professionals with the patient, how they are managing the patients, the clinical process. Examples of the process is the clinical process, the examination, the investigation, the management, complication, education, discharge, even admission. How the process of admission, registration, the care delivery process, registration of the patient, patient ambulation from one department to the other, okay? Cleanliness of the facility, infection control, all of these are part of the process. Administrative process, the information system, how the communication process within the facility, communication within the healthcare organization, okay, and so on. Clear? This is the process. Clear, everyone? Can you? Can you hear me? Okay. Advantage of the process. Advantage of the process, I'm going to have a look, an actual look about what's going on in the process, in the clinical process itself. For example, I can observe a procedure. Like in infection control, you are going to see that in the infection control nurse or the person responsible for the infection control, he's going to do observation and he's going to attend a certain procedure and check for that all the steps of the infection control are being fulfilled. Okay. For example, infection control in a lab. Infection control in while the nurse is withdrawing a blood sample, or a dentist, someone who's going to observe if the dentist is doing or following the infection control measures and so on. So it is done by observation. We are going to attend the interaction between the physician and the patient, or a certain procedure, and I'm going to observe if it is being fulfilled or not. Clear, everyone? Also, we can do interview questionnaires regarding their knowledge about infection control, knowledge about a certain procedure, how the steps of how they do it, and so on. Okay. Its advantage. Okay, you are going to see some healthcare professionals are comfortable with this. They are accepting it, especially if it is for the sake of education. If I'm going to provide feedback about the defects in the process of the professional, and then I'm going to advise him about the treatment plan, about the training, about a certain guideline to follow, and so on. Okay. So, and also I can spot any areas of problems, and I can predict areas where future problems may occur, and I can spot where is the good performance or the good standard, and it can be propagated. For example, if a healthcare professional is very proficient in a certain procedure, this can be a benchmark, internal benchmark for his colleagues. Okay, but the disadvantage here, as I told you, we are doing observation. Okay, so I'm going to sit with a healthcare professional and observe his performance. Okay, you're going to see that some healthcare professionals are accepting this, others will not accept it. They will not accept being observed from by others. So this is a problem. Another thing, that the observation itself can affect the performance of the healthcare professional. He may become, some may provide the best practice during observation and revert back to his original practice after the session ends. Or I can interfere in his performance. He would do errors because he is not comfortable with the observation and so on. Clear? So the observation itself may affect the performance of the healthcare professionals. Clear, everyone? Okay. Regarding the outcome, we had talked about it several times before. The outcome, it is the end result of the process, okay? It's the end result here. And in the outcome, examples of the indicators of the outcome, the mortality, clinical indicators, there is the mortality rates, complications, reported symptoms, level of pain, physiological restoration of physiological function, level, for example, also there is the certain lab test or biochemical, like the level of blood glucose, if it is controlled, if the blood glucose is controlled or not, hemoglobin A1C, blood pressure is an indicator of control of hypertension or not. Functional restoration, the functional restoration after an operation, for example, if the patient can move again and do his job again. Perception, if I had increased the knowledge of the patient and family about the disease, about the complication, about the treatment plan, how to avoid complication, also their satisfaction level, and so on. All of these are related to the outcome approach. And again, in another lecture, we are going to go through the performance indicators for each approach. The structure, we are going to go through the KPI related to this, and the process and outcome. We are going to take examples of the different performance indicators that we can measure these, okay, in another lecture. Regarding the advantage of the outcome approach, it is the final evidence of quality, okay? If I'm providing a good quality service, so it is the end result, okay? And it's easy, we can do surveys like satisfaction surveys to the patients, and this would reflect the quality of care. But take care. As I mentioned before, patient satisfaction is going to be affected by other factors. For example, the educational level is going to affect the patient satisfaction. The highly educated person is going to have more expectations, and his needs, he has more knowledge, so he will get dissatisfied more easily than a lower educated person, okay? Another thing, my level of expectation. If I'm expecting a certain procedure and then I got something else, this may affect my satisfaction. Clear, everyone? So right now you can compare between these three. Okay. Regarding the limitation of the outcome approach, as I told you, it's going to be affected with other factors. It's expensive. If I'm doing a cohort or a follow-up, It's going to be expensive. I'm going to get a lot of dropped out patients, and it's costly. It's going to be costly. Okay. Right now, regarding the criteria and standard, I'm going to skip it, and it's going to be your duty to read the criteria and standard, and you are going to provide examples for them. Okay. Next week it's going to be self-paced. So I'm going to upload the material. And one of the things that you should do is that you are going to provide me with examples. Have a look at this table. This table